Happy Tuesday, everyone, and welcome to Get Your TMD Questions Answered with Transform Dental Sleep and Dr. Jamison Spencer. It's that time of year. Everyone's getting ready for Thanksgiving, unless you're Canadian, at which I hope you had a nice Thanksgiving. But also, everyone's checking with their labs to find out what the deadlines are to get cases in for the year. So if you haven't already checked with your labs, make sure you do so. There's a lot of people that need your help before the end of the year. I want to say thank you to all of you for being here. There's a trillion other things you can be doing on a Tuesday evening. So your dedication to your patients, your practice, and the profession is truly admirable. Thank you. And I also want to thank tonight, we only have one panelist. So I don't know that it's really a panel as much as a dialogue with, as far as I'm concerned, the absolute best lecturer in the field of dental sleep medicine, Dr. Jamison Spencer. I could prattle on about you, but why don't you share a little bit with everyone about who you are and why you're here?
Well, thank you, Jason. That's very kind of you to say about the best lecture, but I will, I'm sure you've heard me use this bad joke before, but whenever people say that about me, that I'm the best speaker they've heard, I always say, well, that's because I'm a speaker in the dental field. That's kind of like somebody coming up to you and saying, Jameson, you're the best, or Jason, you're the best basketball player in our entire bowling league. Okay, so my competition's pretty not that awesome. So one of the unique aspects of my career is I went right out of dental school into a limited TMD practice. Very few people have done that. I took over a guy's practice in Boise. That's where I'm from Boise. So my wife and I wanted to go back home, took over this guy's practice, and that's all I've done. So 26 years now, limited to TMD and sleep. We started doing the sleep apnea stuff in about 2000 after taking over that practice in 98. Now I'm blessed. I have a partner that runs my Boise practice. That's Dr. Cameron Keeney. He's my nephew. And we bought a practice in Salt Lake. And I ran that like myself for a few months and then was blessed to run into a dentist that had been a assistant for Cameron and myself, had gone to Tufts, Army, and I run into him because I was doing some training for Army dentists, and he now runs the practice in Salt Lake. So I mostly spend my time now helping dentists in the US and around the world learn more about sleep and TMD and help their patients.
Well, I appreciate you being here and sharing so openly tonight with all the attendees. Before we dive into the questions, one quick housekeeping matter. You can type in, or a couple quick housekeeping matters. Down at the bottom, you can type in the chat. My homeboy Elias Kalanzis is in there. He'll try to address your questions. We'll try to get to all of them tonight. So please submit your questions. This is very much a dialogue between all of us, Dr. Spencer and all of you. So we'll kind of filter those through to Dr. Spencer. Also, if you stay on until the webinar's conclusion, you will receive an email within the next 48 hours with your CE certificate. That means don't email me in an hour asking where your CE certificate is. You'll receive it in the next 48 hours. If you don't have it by Thursday evening, then shoot me an email. Also, you know what? No more also. Let's go. We got a lot to cover tonight. A lot of really good, insightful questions came in. So let's go with our first question. And that is, what red flags should I be looking for with sleep patients that may develop TMD symptoms as a result of oat usage?
Okay. So I think the biggest one, let's start there, that is missed super frequently is a patient who has evidence of lateral bruxism, or what I refer to as historical lateral bruxism, because if they have wear on their teeth, that doesn't mean that they're currently grinding, but it means that they have in the past. But a person with historical lateral bruxism, and then you give them an appliance that does not allow their jaw to move side to side. And that is by far the biggest one. And this is frustrating for patients. It's frustrating for the dentists. The patients won't often break those appliances, especially some of the newer appliances that are more robust. So they'll break themselves, I like to say. So they will use their muscles and result in muscle pain, stuff like that. So that's the biggest one. If you think the person has a probability that they're going to be a lateral bruxer, give them an appliance that allows them to move their jaw side to side. Okay, so that's one. Number two is
real quick, James, just to clear that up. So a patient like that, then a dorsal probably isn't a good idea.
Correct, and that, again, that's the biggest mistake that's made is, you know, this is less of the case now, but 10 years ago, if you were taking a class on dental sleep medicine, it was probably given by a lab, right? And so sometimes people were taught about a specific appliance because that was the company teaching them. And so they like, that's their appliance. And I'll run into dentists all the time in my courses that's like, I use and then they say that one appliance, and that's what their patients get regardless of the patient. And that's a mistake. So we want to match the appliance to the patient and what's going on, and then you'll have a lot less side effects. Okay.
Got it.
Number two, disc displacement. So if you have a patient that has a reducing disc displacement, which is that popping, clicking, then the person, so this is a little bit different than your question because it's like may develop TMD. This will be the opposite. So this is a person that their TMJ problem is actually going to get better with oral appliance therapy because they're going to be on that disc for 6, 7, 8 hours a day. Prior to that, they'd been on the disc very little throughout the day because remember, they're only on when it pops into place. But the presentation could be, hey, doc, my teeth don't fit together anymore. And what can be confusing for the treating dentist there is the dentist often won't ask either in advance, did they have any problems? But if they just ask at that point, all right, so you're well, and Jason, let me give you kind of the reality here. What usually happens in this case is the patient comes in, let's say for a hygiene check. The hygienist says bite down on your back teeth. The patient bites on their front teeth. That happens to hygienists, 80% of the time, so that's no big deal. But then the hygienist is trying to get that patient to get their back teeth to touch, and they can't. At this point, alarm bells go off. Hey, I think your bite's changed here. And then the fascinating thing is if you ask that patient, did you ever have a problem with your jaw? That's when they'll typically say, well, actually, yeah, now that you mention it, I used to have jaw pain. I used to have this. I used to have headaches on the right side, but I haven't for X number of months. So that'll be a little bit of a reverse of your question, but it can still be a frustration because if we didn't pick up on that, then the dentist and the patient could be kind of frustrated. And then what gets worse is the dentist like, oh my gosh, go without your appliance. Now that disc displacement comes back, the patient starts having pain again, and sometimes they'll give up.
Which is a great segue into, I think, the next question, which is, how do you determine if the pain is muscular or if it's joint related? And how useful is CBCT? And when should they just refer a patient out for an MRI?
Okay, so
there's a lot to unpack there, I know.
Yeah. So muscular versus intracapsular is mostly on your examination. So you're going to palpate, and they can have both intracapsular, so on the jaw joint, inside the jaw joint, and muscle. But typically, I also call it the one finger test. Have the patient point with one finger to where it hurts the most, and that'll help you narrow it down. If it is in the jaw joint too, then there's going to be some telltale signs. The biggest one is typically a posterior open bite on the affected side. Okay. So this is called a retrodiscitis. Many of you have heard me talk about this before. So if you have a inflammation of the retrodiscal tissue, and this happens, by the way, we've got a question later on about AM aligners, I call it a morning reprogrammer, stuff like that. So a lot of patients, we scare them to death about their bite changing. And so then they use that little thing you give them in the morning, and they take their appliance out, and they're like, oh crap, doctor said that if I don't use this thing, my bite's going to screw up. And so then they put it in ugh. So I wrote an article once. I called it the morning re-injurer because it injures the patient. So that's something to be cautious of, because when that jaw's been held forward for 6, 7, 8 hours, there's fluid in the joint. Just that's just the way the body works. There's no space in the body. There's potential spaces. So all of us dentists heard that in anatomy. So you hold that joint forward, there's going to be some fluid there. It's a closed system. It's a basketball around that joint. Now I go to close my teeth together with all those elevator muscles, and I can cause a hydraulic force that those tissues can't handle. And that's how you can hurt yourself. So again, if it is in the jaw joint, then typically they'll have a swelling there. And how you differentiate that is when they bite down, that'll hurt. If you put something between their teeth, like a tongue depressor, but I've got a pen in my hand, this between their back teeth, they'll bite on that. That won't hurt at all. Muscular pain, on the other hand, if I had muscular pain and I bit on my pen here, that would still hurt because I'd be activating those muscles. Okay, imaging. So cone beam CT is useful. I love cone beam CT. I think every sleep apnea patient should get a cone beam CT, because not maybe because of why you think or why the viewers would think here. I sort of care about the airway, but not as much as a lot of people do. I take my cone beam CTs like everybody else, with the patient sitting up or standing up now, fully awake. Okay, they're not in REM sleep, they're not laying down. So I've seen people with really tiny airways on the cone beam CT that don't have sleep apnea. I've seen people with pretty big airways on the cone beam CT who do have sleep apnea. So for me, the size of the airway is just kind of more of a check in the, yeah, that's normal-ish, that's small-ish, that's big-ish. But what I'm really looking for is I want to look at the jaw joints, and I want documentation of where all this stuff was before we started screwing with it. So I really want that in 3D, so that if 5 years from now something's going on, we can look and figure that out. Also, I will tell one scary story with a good outcome that's pro cone beam CT, and everybody can use this story with your patients, by the way. So we had an 18-year-old girl. She comes in with sleep apnea. She had gone off to college. She's like flunking out of school. Her parents are like, it's because you're partying and stuff. You're not going to class. She's like, no, mom and dad, I'm just tired all the time. It's super weird. She gets a sleep study, had moderate sleep apnea, gets sent to us because she's an 18-year-old girl, and the doc's like, you're not going to use CPAP anyway, so let's send you here. We do a cone beam CT. She's got a big old mass at the base of her tongue. So she had a base of tongue tumor. Luckily, it was benign. We actually did fit her with the oral appliance because she didn't have time to go get this thing removed till the school got out. She wears the appliance for a couple months, does great with her finals and stuff, goes in the summer, gets the mass removed, and she's doesn't have sleep apnea anymore. So I love telling that story because we were the only ones to look. The sleep doctor didn't look down her throat far enough to see that. Had we not had the cone beam, we wouldn't have known. So back to the jaw joint stuff though. Cone beam CT is awesome for bone. When would you get an MRI? Well, if you think there's something going on with the soft tissue. So if you think that the person has a disc displacement, then you could get an MRI. MRI, the nice thing about MRI is there's no radiation. So I'd rather you get an MRI than stick someone in a cone beam CT twice, right? Because you're irradiating them. MRI, that's not the case. But, is it going to change how you treat somebody? Not necessarily. So if you get the MRI and you're like, oh, I thought you had a disc out of place. Sure enough, you got a disc out of place. And I'm still going to treat you with this appliance, right? The only thing that's going to change in your life there is you're going to explain to the patient, hey, you've got this disc out of place in front of your condyle. You got this disc thing here. We're going to kind of put pressure on that you've never done before. It's possible that could result in some issue here. And also it's actually possible that disc could decide one day to pop back into place. Now, this is a curious thing for the viewers if they've never had this happen before, but eventually you'll have somebody that goes from non-reducing disc displacement, disc out of place, stuck, to popping when they're doing oral appliance therapy. Now that's good. Okay, that's a step in the right direction for that jaw joint. Never will a patient be like, awesome, right? So no patient is out there thinking, hey, my jaw used to click when I was 16. It went away in my 20s. I'm now 45 and it just started clicking again. Hot dog. I'm back to like when I was 18 years old. No one will think that. I had a patient actually, Jason, that was, he would winter down in what's that? There's a huge, I know there's a bajillion retirement communities there. Sun Village or something.
Sun City.
Yeah,
Sun City. He was
yeah.
in Sun City, and he was in Boise during the summers. He would go down there in the winter, and this happened to him. And I was like, hey, that's awesome. Good for you. You're like 72 years old. That means your joint's in better than it was before. He's like, well, I'm glad you think so, but I hate this clicking. What can you do? So I actually gave him exercises to get him back off the disc.
Oh, and that was after explaining everything to him.
Yeah.
Still.
So we always, hang on just a second, if you don't mind.
Sure.
It's on the webinar, but I'm going to grab something if I can find it. There it is. It was sitting right next to me, actually.
Hey, Jason Doucette, we're going to get to your question, by the way.
So I have, and I strongly encourage everybody to get this if you don't have it already. So this is called the TMJ Tutor or TMJ Demonstrator. You can get these from Great Lakes Orthodontics. Probably if you mention Jason's name or mine, they'll give you a little discount because I think we're both work well with Great Lakes Orthodontics. They're good folks over there. So this TMJ Tutor, TMJ Demonstrator, and I think there might be videos of me on YouTube or Cameron on YouTube showing how to use this, but this is worth its weight in gold, like legit, because you can explain to the patient what's going on in the jaw joint. Now, a second ago, I did this number. Now, that only is meaningful to dentists. Almost all of you are doing this crap with your patients, and I'm really good at it. Like I can make it click like that. Okay, I can like really show it. That patient has no freaking clue what you're doing. Okay, they have no understanding. Yeah. Whereas the TMJ Tutor, they'll get it. They'll bring their spouses in. They'll be like, oh, show them that black and white thing. And the new ones now are a whiteboard and you can draw on it. You can draw the airway and stuff. They're pretty cool. So I would get that if I were you. Just the bottom line, and a lot of these questions of like side effects, the most important thing you can do with side effects is avoid side effects by teaching the patient what's going on in their jaw joint. Now, here's something, Jason, I'll share with you that has had me a little bit upset. Okay. I almost used the word depressed there, but that's not really a word that's in my vocabulary, but maybe someone else would use that term. When I lecture, I will ask dentists, hey, who in here has a nice loud click? You open really loud crack, and I'll find somebody and then I'll kind of go through this whole thing and explaining it and stuff. And I've done that for 10 years. But this last year, one time I was just like, I'm gonna ask this person. And I said, hey, just curious, I hate to put you on the spot like this, but did you know that you were clicking into place? Did you know that you were clicking on to the disc? And so far, I've done that now probably a dozen times in the last year at big dental meetings. And so far, I'm batting 1,000. Everyone I've asked did not know that their jaw was popping into position. And these are all dental professionals, obviously. That's who I lecture to, not, the steel workers of Pennsylvania or something. These are all dental professionals, hygienists and dentists had no idea that their jaw was clicking into place. So our patients have no clue on this stuff. So
this is precisely why that's why this is so valuable.
Totally. So step one for you dentists, figure it out yourself so that you can then educate your patient. And then, Jason, a few years ago, I got almost blacklisted at the ADSM meeting because I spoke there and I said from the podium, dental sleep medicine is easy as long as you're an expert in TMD. And the leadership at the time did not care for that statement that I just made, but it's true. You know this, Jason. I mean, half of the people you've worked with over the years we came from TMD. And this dental sleep medicine stuff is actually pretty easy if you came from a TMD world. If you go the other direction, TMD can be a little bit frustrating or invigorating, depending on how you look at it. But that's the key. Figure out this stuff yourself so you can educate your patient. Then when that happens, you can be like, oh my gosh, your jaw's clicking? You got to be kidding me. That's a flippin' miracle. That's amazing. And then if the patient's like, okay, I'm glad you're stoked about it, but I don't like it. All right, well, I can get you dislocated again. Here's the way that we'll do that. Here's the exercise I'll give you to re-dislocate your jaw.
Yeah. Well, I like the idea of using that TMJ tool from Great Lakes as a visual rather than showing patients the yoint videos.
Correct. Yeah. Quick story on that, Jason. I've had like I can count on one hand the number of people that have passed out in my office. But one time I took a group of Boy Scouts. This is probably 20 years ago. And I was like, you know what would be cool for these 12-year-old boys? Because, you know, they're going to think this is all lame, I'm sure. And I'm like, I'm going to show them the yoint videos. And I had a kid hit the ground. I had to put him on oxygen and everything.
And that was the last time you led a hike.
That's right.
So in the morning, a patient takes out their mandibular advancement device. What should they be doing? What should dentists that are on here tonight or team members that are on here tonight communicating with patients? What should they instruct these patients to do for the sake of the joint?
Okay, so, and I'll answer this question the way it's written here too, on which morning aligner. So the big thing for me, for a whatever you want to call this thing, so I use the term for mine as a morning reprogrammer. Jason knows this. I like making up words. So that's not in the dictionary. Reprogrammer is the opposite of everybody put in the chat, you don't have to.
Deprogrammer.
There you go. Yeah, Jason knows that. So that's the opposite of a deprogrammer. What's a deprogrammer? Well, a deprogrammer, dentists think of, well, something like an NTI is a deprogrammer. And then I follow up with the question, what's the program? And then most dentists like, what are you talking about? Well, what's the program? What are you deprogramming with a deprogrammer? And they'll be like, well, you know, the muscle engrams and the you know, it's kind of, that's the program. Where the teeth fit, that's the program. So anything you put between the teeth is a deprogrammer. Just a standard night guard is a mild deprogrammer. Something that holds your jaw for 6, 7, 8 hours is a major deprogrammer. So we want to use something to get that bite back. As such, I want something that allows proprioception. So the ones we use and that I teach is just in the front so that the person can have full posterior occlusion. Shim stock level holding posterior occlusion. Why? So that they feel their bite and their brain goes, oh yeah, that's where my teeth fit. Now, we make that on every patient. Everyone gets that. Now, let me tell you the tale of two bites. One is a guy who wears an appliance almost every night and has for years, and it's worn every style of appliance that there is. And my bite goes back to normal. Oh, I gave it away, didn't I? The guy in this story is me. So my bite goes back to normal within 2 hours, and I never do anything. I don't do exercises. I don't stretch my jaw. I don't do any of that stuff. It just goes back. I am representative of minimum half of your patients, maybe as high as 70%, where it just goes back. We're good. For those patients, they still got it because I'm not smart enough, and maybe there is someone out there who is smart enough to have figured this out, but I can't look at a patient yet and go, yeah, you're going to have a problem, or no, you're not going to have a problem. So we make everyone one of these things, and we tell them, hey, take your appliance out in the morning, go about your business, take your shower, get ready for work, do your thing, maybe eat breakfast if you're a breakfast person, and then check after a couple hours, does your bite feel pretty much normal? And if it does, you're good. If it's feeling a little weird, then pop this thing in, squeeze, 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 or maybe you do it on your way to work. Maybe you chew some gum on your way to work. bottom line, most important is before you go to bed. Okay, so this is what we give all of our patients. Before you go to bed, I want you to floss like a boss, check your bite every night. Floss is making sure your teeth haven't moved. Bite every night. It's like, yep, same as yesterday. My friend Nancy Addy, she came up with a cool idea, which is you get those little plastic post-it note thingies like you use to mark a page in a book, made out of plastic, not paper. And she will get those, give them to her patients, and then they use that as shim stock at their house to make sure they can hold it. Smart idea. Now, the tail of the other bite is my wife. So she has had an appliance for years, and she developed a posterior open bite. And because her dentist sucked, okay? So me, of course. So, you know how it goes with family. They don't get necessarily the best follow-up and stuff like that.
No.
So she develops a posterior open bite. And then a few years ago, she'd never loved her smile anyway. And so, I know a lot of dentists, and I'm like, hey, this cool dentist, could you do my wife's smile redesign? He's like, sure. So they rebuilt her to that new vertical. And I anticipated this was going to happen, but still, there's a lot of people maybe on this call right now are like, well, yeah, man, you just, old bite bad, new bite good. We're just going to bring them into that new jaw position and crown their teeth or put them together there orthodontically and boom, we're good to go. Nah, are you? So she goes back to wearing her oral appliance after having her teeth redone, because just because her teeth were redone didn't mean that her jaw couldn't fall back still. Jaw could still fall back. She wears that oral appliance, and I'll be damned if she doesn't develop a posterior open bite again. So she struggles every day to get her bite back. Okay, her jaw just wants to be forward. So she uses her morning reprogrammer almost every day in order to get that bite back. We're talking after full mouth reconstruction. So everybody out there, again, make it for everybody. Make sure they know how to use it. Follow up with them appropriately. Vast majority of your patients won't need it. Some of your patients will need it a little, and some of your patients will need it every day.
And what material are you using for those reprogrammers?
So I still use Thermacryl Plus, I think is the best. It doesn't shrink. It's easy to do. The bummer with it is it looks like chewed up gum. It is easy to be discarded. So some people, and we're close to doing this, we haven't done it yet though, but some of my friends are printing them, 3D printing them. That's probably smart because there's a little higher value in that and less likely the patient just to throw it in the trash, especially if you charge them $150 for it. But right now, currently, we fit a Thermacryl made chair side right there. We're checking with shim stock. That's what we do.
Inexpensive and pretty quick.
Yeah, we charge nothing for it, of course, and it's part of their treatment, and it's a very, very simple thing to do, very inexpensive to make.
Sure. Let's switch gears if we can for a moment from mandibular advancement devices to talking about more traditional splints, night guards. This question came through, or some variation of this question came through from several people. But can you just share a little bit about when you would use a flat plane splint, a traditional, full arch night guard, whether with or without guidance, versus an NTI, and when you wouldn't use each one?
Yeah, sure. So in our practice, so you got to all take this with the grain of salt appropriate here. Recognize that we don't see normal people. We only see patients with TMJ problems. So the vast majority of our patients have already received a night guard from their dentist. So we virtually never do a flat plane night guard, ever. Why? Because I don't want to be surprised where their jaw goes. I want to be in control of where their jaw goes. So we use an appliance that I kind of refer to as the airway-friendly night guard, historically known as the FARRAR, F-A-R-R-A-R style night guard. Has a little ramp on it so that every time the person closes when they swallow, regardless if they're on their backside, stomach, doesn't matter. Every time they close, their jaw will go into a specific position. The nice thing about that appliance too, with its little ramp, is you can add a little acrylic and create this anterior stop, as is mentioned there, if you want to. So why would you do that? And maybe to back up just a little bit, in our practice, we also don't fit any type of night guard, and particularly not an NTI, until we've ruled out sleep apnea. Okay, so if there's
And
a
that's done via a sleep test
yeah. So if there's a
every time.
hint that they
Okay.
might have sleep apnea, and in vastly majority of these cases, there is a hint they have sleep apnea, we will rule that out first. Everyone on here is familiar with the literature that bruxism can sometimes be related to an airway issue, that sometimes a appliance can result in a worsening. So we want to rule in or out that airway issue before we just start putting things in people's mouths. I don't see and never have seen an appliance, an NTI, a night guard of any sort. I feel all of these are the same thing. And that is, so my analogy is your patient is banging their head against the wall and you give them a helmet. That's what an occlusal guard is. I don't care if it's an NTI, I don't care if it's a COISTE program, I don't care what it is. It's a helmet. They're just different styles of helmets. Okay. And your theory is they're going to continue this behavior. And I'm just going to give them something that makes it hurt them less. I'm going to give them something that mechanically makes it so the muscles can't contract as much. That'd be an NTI. So that's okay. But whenever we're doing something like that, it's because, quote, we're not smart enough to understand why you're grinding your teeth. This is the same. I can't remember if there's any questions that came in about Botox, but this is my same feeling on Botox. Yes, we use Botox in our practice after we've ruled out sleep apnea and to help the patient have some pain relief because we're not smart enough to know why they're doing it. Okay. So no one has a TMJ problem because of a Botox deficiency. No one has a TMJ problem because of a acrylic deficiency. So we're using these things to mechanically alter stuff or turn off muscles, but that's not the etiology. Whereas sleep apnea, sometimes we get lucky, and that's the best is they have sleep apnea. So these people that we screen for sleep apnea, oftentimes they could put on CPAP because I work with sleep docs that really like CPAP. I mean, they really, really, really like it. And so they'll
A
put them on
lot of them
CPAP.
do.
You know what? I found that, Jason, around
Yeah.
the world. I found that. So they'll put them on CPAP. Patient comes back in, jaw problem's gone on CPAP. So
Uh-huh.
that's nice.
Yeah.
I wish that happened every day. That'd be awesome. It doesn't.
Sure.
So
So with a mandibular advancement device, when do you add an anterior point stop,
so good
like
question.
an NTI bump?
Yeah, actually, awesome question. So there we got a scenario. This is what I said a second ago. I wish that airway was always, I wish bruxism was always airway related. That'd be awesome.
Sure.
It's not. So we've treated hundreds of patients, probably thousands at this point, that you fit them with an oral appliance, a mandibular advancement device for their sleep apnea, and they still grind. And they'll have an AHI of 0. You know, they're feeling awesome. Their snoring's gone, and they're grinding the crap out of this appliance. Then we do all the stuff. So then we give mechanical advantage to the appliance, if you will. We'll add an anterior point stop. We'll do various things. This now, and I think you might have this on a question here. There's a lot of people that disagree with me on this, but this is why one of my favorite appliances is actually the EMA because the bands will stretch and break. And as I like to say, I'd rather have the appliance break than the patient break. So when we believe a patient is really putting on some weird forces at night and we know it's not their airway anymore, that's protected, and we've checked out the drugs that they're on and we're looking at all this other stuff, but still we just aren't smart enough to figure out what it is yet, we will ideally have them in appliance that the appliance will be the weak link.
Got it. What about, so switching gears again,
Sure.
now we're getting away from appliances altogether. What about PRF as a treatment for TMD? I know that you're a proponent of it, but when should dentists consider using this, how, for whom, et cetera?
Okay. And I'm going to talk a ton about this, Jason, at the program at Transform Dental Sleep Medicine. I could not be more excited about. Let me say it this way: I have never been more excited about anything in my career than PRF. Pretty much a day goes by that I don't talk about PRF to someone, but not just about in the jaw joint. So ran into a friend in my neighborhood who's having back surgery, and I talked to him about it. When my wife had her shoulder surgery, I talked to the surgeon about it. This PRF, PRP, platelet-rich plasma, platelet-rich fibrin, is revolutionary, and we are seeing results. So for those who come to the meeting, they're going to see before and after cone beams that will blow their flipping minds. And what's amazing is even on the patients so far, so we're seeing cortical plate come back, we're seeing arthritic conditions reversed, literally. And even in the cases where we don't see arthritic changes reversing, the patients are still reporting significantly less pain and dysfunction. I've taught this now to a few hundred dentists. Mostly Spencer Study Club members are doing this stuff. And so it's not just, my practice in Salt Lake or Boise. There's dozens of practices doing this around the country, and the results are all the same. I want people learning how to do this. So the hurdle is learning how to stick a needle in the jaw joint right here. And it's not brain surgery if you do it right. Did you get that joke?
If you do it right. Yes, I did. Hence the smirk. Yeah, you actually you filmed a kind of a promotional video for your presentation at the symposium, and you shared some images.
That's
from
right.
I forgot her name, but doctor in the Seattle area, I think.
Yeah. Dr.
And
Kushner.
those images were, yes, Tanya Kushner. Yeah, those images were mind blowing.
Yeah, and she just sent me a couple weeks ago the follow up to those 6 months later, and
Mhm.
it's even better. So yeah, we're
Wow.
just seeing this all the time. It's literally shocking. And I probably shared with there like we've seen the disc itself repair, mind blowing stuff. So I'm pretty sure,
Wow.
Jason, within a couple years, I will be teaching people here's how to give a jaw joint injection, give the patient a jaw joint injection, and give them an aqualizer, a water-filled
Mhm.
splint. And that's it.
Yeah.
And you'll probably have
Wow.
90+% of your patients getting better.
Game changer.
Game
Well,
changer.
everyone, make sure you come to the Transform Dental Sleep Symposium. Then it's January 31st and February 1st in Scottsdale. This previous February was our inaugural meeting. It was very well received. I actually asked Dr. Spencer if he could speak then, but he had a Spencer Study Club, one of his own events. I was unable to make it, so we're really honored that he's going to join us this time. He just shared a little bit about what his topic will be, and I am certain you will be swarmed when you leave the stage with questions, Jamison.
I hope so.
I mean, just what a potential breakthrough and real game changer. So looking forward to it, everyone. If you're not registered, we are nearing a sellout already. There are last I checked, there were 30 hotel rooms remaining. So that's not just in our discounted block. We blocked the entire venue. So if you haven't registered, get registered, book your rooms, and it's going to be incredible. A veritable who's who of speakers on practical topics that you'll be able to take back with you. And as long as you put it into practice, it will be a benefit to you, your practice, and your patients. So go to tdssymposium.com, get registered. And with that, let's dive back into the questions. There we go. You talked a little bit about your wife's posterior open bite again. What do you do when it happens? I mean, you shared what happened with your wife, but when a patient comes in, well, let me pause actually. Let me ask this differently.
Okay.
I know work over the years working with dentists, especially years ago in a past life in a dental lab. dentists would call me, and I mean, they threatened to sue. This appliance changed my patient's bite. They're threatening to sue me. I'm going to sue you, and all this stuff. So there's a freak out moment. So when that happens to a dentist, what do you say to that person?
Okay, excellent. So here's another reason for you to get a cone beam CT, and very huge advocate of you all being scanning. So if you don't have a scanner, get a scanner and scan all of your patients. So step one, and often what happens there, Jason, and I'm sure you experience this, is sometimes it's someone like that's on this call right now has fit a patient, but that patient has a dentist. That's not them. Okay, like all of my patients have a real dentist. Okay, we don't do real dentistry, so they're all going back to their dentist, and then that patient has a posterior open bite, and then all hell breaks loose. And luckily for me, we have a good enough reputation that the dentists don't typically say you should sue that SOB because their appliance did whatever. And some of the comments, though, of what the appliance did are really mind-boggling, but it's because this is what we were taught. So they'll see that, and some dentists will be like, oh, that appliance caused all of your front teeth to grow, to extrude. That appliance intruded all of your posterior teeth. That's what they're going to say. And it's like, so because they've never understood that you bring the jaw forward a couple millimeters and your back teeth don't touch. I don't understand how they don't know that, but they don't get it. So step one is you get new impressions of that patient's teeth or new scans, models, and you stick those suckers together. And you're going to be able to see, hey, the teeth still go together. If we were to take those jaws out of your head, we could still stick them together. So the reason your bite's weird is your lower jaw is holding itself in a different position. Now, if you made that morning reprogrammer, this is where you say, do you still have the morning reprogrammer? And again, they may say, oh, that chewed up gum thing that you gave me? No, I threw that away a long time ago, or I've lost it or whatever. You can make it on the models, okay? If you're printing them, you could print it. If you use a company that gives you one of those that's milled and or printed, you could call that company. They'll make you another one. And then that person could start using that same thing. It's going to fit just fine on the upper. When they go to bite into it, they clearly won't be able to easily, but based on the design, that should help to return their jaw to normal. So that would be, again, step one, models showing that nothing's moved. Two, morning reprogrammer now after the fact to get that jaw to go back. Most of the time, oh, and three, and perhaps most important, if you have the patient doing this exercise to get their jaw back, how effective do you think it's going to be for them to do this exercise 20, 30 minutes a day? Let's go crazy. Let's say the patient's doing the exercises with the morning reprogrammer 4 hours a day.
Okay.
Jason, what are they going to do that's going to get rid of that 4 hours a day of exercises?
What are they going? I don't know that I understand the question.
What are they going? So they're doing their exercises all dang day long, 4 hours a day.
Yeah.
But what are they going to do at night? It's going to screw it all up. Where they're appliance again.
Yeah, they're not in that position. Yeah.
Okay. So the biggest problem with this is these patients that have a posterior open bite almost always are doing awesome. They're feeling better. They're not snoring. They're back in bed with their bed partner. They're doing great at work, right? And you're like, well, we're going to take that away. They're like, no, you're not. Mm-hmm. And then as a dentist, you got to be like, hey, we're taking that away and you need to go back on your CPAP. And they're like, dude, no. So if you don't take the appliance away at night, it won't matter what they're doing for exercises. They're not going to get their bite back. So if the person is really wants to get that bite back, then it's all right. I need you to go without your appliance for a while. I need you to do these exercises as much as you possibly can. And then as soon as you get your bite to touch again, I need you to spend a few days to get that program reprogrammed. Then we go back to wearing your appliance again. I've done this. We have successfully gotten people's bites back multiple times. However, I've had plenty of patients that just weren't willing to go without their appliance.
Yeah, sure. What about this is a question that came through from Dr. Stacy. what about a patient that's in a mandibular advancement device? They've got an anterior disc excluder. All of their sleep symptoms have been improved. Objectively, the results have improved, but they still have some muscle pain and tension.
I guess I would be it depends. So, as I mentioned before, you can have people with a protected airway. So, step one, because that wasn't necessarily clear on that, is I would get a sleep study. So, one thing too that we're huge advocates of, that I understand the vast majority of you are going to have a very hard time doing this, but it's still worth a try, is we still in our Boise practice, I wish we could do this in our Utah practice as well. In our Boise practice, almost every patient, their oral appliance is titrated live in the sleep lab. So we're never wondering what would another millimeter do. What would going back a millimeter do? We don't wonder those things, and we also don't wonder about bruxism because we see it in real time on the PSG. Okay, most of you aren't going to be able to do that. So what you are going to be able to do though, so in Spencer Study Club, this stuff comes up all the time. Yeah, they're snoring less, they're feeling better, whatever. They're having muscle pain still. My first question is going to be, is the appliance working? And what I mean by that is it protecting the airway? And what I mean by that is, do you have objective follow-up showing that the airway is protected? And if you do, then now we go back to this mechanical, like again, an NTI type of approach, Botox if you have to, really looking at the diagnosis, what's going on in their diet. Are they on any SSRIs? There's a whole, and I can't list them off the top of my head. SRIs are the biggest one, but there's like a bajillion medications that can cause people to clench and grind their teeth. And so don't always throw the appliance under the bus. Maybe try to figure out, why are you doing this in the first place?
Got it. Is there a particular device that you recommend or that you use more than others to avoid? Is there a device that's been shown to cause less side effects?
No, definitely not. So the appliance choice is so my little joke that's not a joke. Whenever I lecture to a group that's kind of new, I'll be like, hey, there's 100 plus FDA approved appliances. Why don't I just cut to the chase and tell you what's the best one? Would you guys like that? And they're like, hey, the best appliance, just tell us what it is. And they'll have their pens ready to go to write it down. They can't wait for me to tell them the one best appliance. Yeah. And then I'll say the one best appliance is the one the patient will actually use.
Sure.
And notice I didn't say the one that works, because it doesn't matter if there was some magical appliance that always took the HI to 0. We sort of have that. It's called CPAP to a degree. But if there was a magical oral appliance that did the same thing, but the patient wouldn't wear it, then it doesn't matter. So the real key parts there is an appliance that the patient's going to use. However, as we discussed half an hour ago, just don't make the mistake of on the lateral grinder. That's going to be the big one. If they have evidence of lateral bruxism, you give them a dorsal style appliance. Not always will they have a problem, because sometimes protecting their airway will have a reduction in the parafunction, but oftentimes that is going to cause some muscle pain, maybe even some joint pain. As I mentioned before too, one of the reasons I like the EMA appliance, which is unique on the market, is those elastic bands. They tell me a lot. So they tell me when the person is clenching, grinding, doing various weird things with their jaw, because it will show up in those bands on the stretching of it really quick. Sure. Whereas Herbst, for example, they might be doing the exact same thing, but I can't tell until they break the appliance. And whenever someone breaks an appliance in your practice, you should be asking yourself the question, how long did it take them to break that? It wasn't one night, right? So it probably took months. And then where did those forces go that were placed on it until it broke? Okay. So I like I said, I'd rather have the appliance be the weak link. The example I use with my patients is, hey, this appliance is kind of like a BMW or a Mercedes. It has built-in crumple zones. So those cars, if you're in an accident, the car's destroyed and you're alive. With this
Mhm.
appliance, you could be doing some weird stuff here. The appliance, these things could stretch, maybe even break. You'll be all right. So that tends to be my go-to for people with a history of TMJ problems that are just scared, people that have
Mhm.
spent a bunch of money on their teeth, veneers, implants, whatever. Like dental implants, all of us dentists know that's awesome. That's like, steel into the jaw and it's not going anywhere. It's rebar.
Mhm.
It's awesome. But your patient doesn't think that way. So your patient's like, dude, you better not put any pressure on that thing I spent, 10 grand on. I'm going to be pissed if that fails. So we will try to explain the science to them. And then when they're like, no, let me reiterate, you better not touch that thing, then we grind it out and we don't touch it, even though we know that that's actually better to anchor on that implant. Okay. So kind of a
Sure.
long drawn out question there, but the real key though for me though is make sure the patient's comfortable, and because there to me there is no one perfect appliance. I wish there was.
Yeah.
So even though I like the EMA, for example, if they're missing lower posterior teeth or they don't have good retentive features on their teeth, it's just going to pop off. So we can't use
Yeah.
it. So
W- With
it's always patient dependent.
with the EMA, are you using the printed versions or the kind of the suck down trays?
My
What's
favorite
your
right now is the
preference?
nylon version. The nylon is awesome because it is
Mhm.
indestructible. And then the bands become literally the weak link. The trays will never break. Cameron literally drove over a nylon EMA with his pickup truck and it didn't break. So
Mhm.
that one I like. Many of you may have seen the press release from Lux Creo that
Mhm.
in the coming months, we will be able to print the EMA in-house, and I'm super stoked about that.
Yeah, sure. So you talked a moment ago about, kind of communicating concerns or having conversations about concerns with patients regarding an implant. What about communicating with the patient's dentist about TMD concerns? Um, what does that sound like? I would imagine that you all have quite a bit of that.
Well, yes. However, that's another difficult one to translate into someone else's office because of the unique nature of our office. So, a ton of time, Jason, the majority of our TMD referrals come from general dentists and dental specialists and then ENTs. And roughly 50% of those patients that come in with a TMJ problem of some sort are referred for sleep apnea evaluation and are diagnosed with sleep apnea and stuff like that. Sometimes there is a little bit of, hey, why'd you send my patient for a sleep study? I sent him to you for a TMJ problem. And that's easy for us to kind of explain. Well, we're trying to get to the etiology of their problem, and this could be related. And, even though that science has been around for several decades, it's mostly ignored and or just completely dentists are ignorant of it. So we talk about that. People that have an underlying TMJ problem, that's another group of people that will be sent to us on purpose. So even if the dentist kind of dabbles in dental sleep medicine, they make, Silent from Glidewell for their snoring patients or whatever, they're smart enough to not touch the patient that says, I have TMJ. So they refer
Mhm.
those patients to us on purpose.
Mhm.
But bottom line, and uh, the literature bears us out too, oral appliance therapy for sleep apnea virtually never causes a temporomandibular disorder. On the other hand, it usually helps a temporomandibular
Right.
disorder.
Sure. We've got a few more questions that have been coming through live that I want to jump to. Before we do that, I want to share with everyone a little bit about a special offer that we've got for Spencer Study Club. Uh, if you contact me, that's my email address there, jason at transformdentalsleep.com. We will be giving you a $500 scholarship towards Spencer Study Club membership. And I say this, it's I'm a little envious about what you've created over there, Jameson, because I admire it. I'm a little envious. I have talked to dozens of dentists, probably, I mean, heck, maybe hundreds at this point, that are Spencer Study Club members, and every one of them provides a rave review. I I don't know if you've made a deal with the devil, what you've done, but it's admirable. So if you want to find out what all these people are so jazzed about, if you want to a lot more of what you've gotten tonight, you want to be part of a tribe of people that are moving in the same direction, and you want to accelerate your growth in dental sleep medicine and TMJ treatment. Uh, Email me, Jason at transformdentalsleep.com. I'll get you set up with Spencer Study Club, and you'll save $500 on your membership. Anything you want to add to that, Jameson?
No, that's very kind. And just on your speakers for Transform Dental Sleep, I think about a half dozen of them are members of Spencer Study
Yeah.
Club. But you're right. We've built something real special. I'm blessed that I attract really cool people that are really trying to help their patients and do it in the right way, in the best way they can. We don't sell products, we don't sell appliances, we don't sell equipment, we don't do any of that kind of stuff. So we can be really open on what people need and don't need. And it's that tribe. That's what you're talking about. It's so very rewarding for me, and we have members all over the world. But yeah, I just props to you to kind of steer people in that direction because our real goal is to help every dentist help more people. So we have super experts in there. Like I said, you got about a half dozen that are speaking at your conference, but they're back with Spencer Study Club year after year after year because all of us are always a lot smarter than any of us. And I have members of my study club that have seen cases that I've never seen in my entire career.
Sure.
So it's kind of cool to have. And we also
Yeah.
aren't mean to each other, like on Dental Town or even the ADSM, forum and stuff like that. People can kind of puff their chest and try to be cool. That's
Yeah.
not, we don't have literally any of that in Spencer Study Club. So that's kind of nice.
None of you all are that cool. Yeah.
Exactly.
Uh,
That's right.
yeah. And a quick plug for our next webinar 2 weeks from today. It is the week of Thanksgiving, but it's a couple days beforehand. We're going to talk about something that is vitally important, yet often overlooked and not very sexy. Everybody wants to talk about, devices, which home sleep test, which billing code. The reality is, if you aren't honing your communication skills, you're not going to get. Let me say that differently. Let me put a positive twist on it. If you hone your communication skills, you will get to treat more patients. You will have a reason to focus more on those billing codes and which devices to use because you will treat more patients. So that's really what we're gonna focus on in this webinar. We're going to talk to everything from a dentist to a treatment coordinator, and myself, who wrote a book related to this topic about communication that will help you not only with engaging with your patients, but also engaging with referring physicians and communicating with your team to generate more buy-in. So that's the focus of the next webinar. Get registered for that.
Jason,
And then,
Jason,
yes,
excuse me, the link to register is in the chat box.
it's in the chat box.
Yeah.
And then we also want to remind you that on the day before the Transform Dental Sleep Symposium kicks off, so this will be on January 30th, which is a Thursday, the day before the meeting kicks off. We will be hosting, along with ASAP Pathway, a deep dive on pediatric sleep disorder breathing. So Doctors Michelle Weddle, Stacy Becker, and Tracy Wynn will really focus on the etiology of pediatric sleep disorder breathing, the viable treatment options, and also how to monetize it. There are a lot of courses out there about how to treat these patients, how to help these patients, but not so much about how to turn it into a profitable part of a practice. So this is limited to only 35 attendees. While we'll have hundreds and hundreds at the symposium, this workshop is limited to 35 attendees. So we encourage you to get registered for that. It requires that you register for the symposium, you register for the workshop, but get registered for both, limited to 35. So sign up ASAP. And then lastly, the symposium, once again, you can sign up at tdssymposium.com. I didn't clear this with Elias, but I'm a rebel. I'm an iconoclast. I do what I want. No one can tell me what to do.
Don't do it.
Use the code.
Don't do it.
I'm doing it. Use the code JT100 and you'll save $100 on dentist and team member tuition. So use that. Contact me, Jason at Transform Dental Sleep, to get signed up and save money on Spencer Study Club. It will be the smartest thing you do in the month of November. With that said, we are going to spend 3 more minutes addressing some of these questions. I try to weave them some into the conversation, but we're going to spend 3 minutes real quick. So lightning round, Jamison, you ready?
Yes, but let me put in a plug for that day before. So Stacy, Tracy, and Michelle are 3 of my Spencer Study Club superstars. They're 3 of my members I'm the most proud of. I don't know if you know this or not, but I helped them create ASAP Pathway. And the reason I did that was because I'm passionate too about helping kids. We're almost all adults in my practice. But it's very sad to me that most people that treat kids do so as an expensive hobby. So if you're interested in helping more kiddos and not just having it be an expensive hobby, be one of those lucky people to have one of those 35 seats.
I agree with everything you just said. You mentioned about some exercises. What specific exercises do you give for dislocated jaws?
I'm not even sure what the person means by that.
Yeah.
Sorry.
What? I'm not sure either. Dr. Vijay, if you want to give some clarification, we can touch on that. Can you show us the exercise? Can you show us the exercises you mentioned earlier that will re-dislocate a jaw to eliminate popping in patients that can't tolerate the pop?
Oh, okay, sure. So
I think that's probably the same question, actually.
Okay, if you're trying to get them back off the disc, then you would give them a leaf gauge. That's all it is. So you would give them something to put between their front teeth that they put a retrusive force on to jam their jaw back into what you were taught was CR in dental school. It really isn't CR, but that's what you were taught. So bottom line, leaf gauge, retrusive force, and that's going to hopefully get them back off the disc.
We're going to have to save that CR conversation for another webinar. We don't have enough time. Yeah, no, and nobody can yell at us, via the internet. Yes. Where do we order the night guard that you talked about earlier?
So that's a tough one, and I don't want this to be self-serving, but I even asked my friends at Great Lakes if they did it, and they don't. So. Yeah. So we have a little in-house lab. We don't do this for other than Spencer Study Club members, but if any of your folks want to reach out, so they can email me, Jamison at jamisonspencer.com. I'll connect you with my son, Jack, and then he can connect you with our lab for the Ferris style night guard. My number one way that you should do it is you buy from Glidewell the Ergoform suck down machine, and then the discs, and then you make it in-house. So we make them all in-house. But if you're like, dude, I don't have room for staff or anything else to be making stuff in-house, I don't want to do that, we can make it for you. I bet you that, Sonny Bocala's lab and
Apex.
I bet Apex and True Function.
Apex makes them. Apex makes them. True Function makes them as well. And then I think Great Lakes does, don't they?
You think? I swear that they said I was with Jenny recently, and she's like, I'm not sure what you're talking about. Sonny and what's his name at True Function?
Frank. Yeah.
Frank. Yeah. Those guys. Yeah. Do that. Don't email me to use my crappy lab.
Yeah, we just Sonny gave you the Men in Black thing. We erased your brain. None of you remember that he said that. So reach out to Sonny Bacala at Apex or Frank Madrigal at True Function. Both of them have a deep level of familiarity with those devices
100%.
and can get it dialed in for you.
Yeah,
And they'll
beautiful
also be
craftsmanship.
at the symposium as well. So
There you go.
one more reason to
Absolutely.
come and have a
100%.
conversation with them.
100%.
Let me see. Any other questions here? All the other questions here, we were kind of able to weave it into the dialogue, so we're good.
You
Right on.
said. You said.
Oh yeah. Actually, the very first question that came in was from Jason Doucette. He wants to know if you were able to land a wake surf 360 over the summer.
Many times, Jason. Yes, I've been able to do, I think, 2, maybe 3 in a row. My son, Josh, has been able to do a 720. Can you do that, Jason? Can you do a 720?
I can't.
Jason?
Well, I know you're asking Doucette, but I can't do a 720 just standing up and I can't walk
Me
in a
neither.
circle
I would tip
twice.
over, that's for
Right.
sure.
Right.
Good point.
Well, I want to say thank you, Jameson. I mean, you are such a fount of knowledge, and for you to spend the time to share so openly with everyone tonight, with us, I really appreciate it. It's a testament to who you are, and as you mentioned, your desire to help more dentists, help more people. I think you've done that tonight. That means the onus is on every one of you to take what you've learned tonight and put it into practice. Else, this was all just for naught. It was all just something to make you a little more boring during dinner table discussions. And that's not who you want to be. So take this, put it into practice, get registered for the symposium, tdssymposium.com. I've already gotten 2 emails just since we've been talking from people that want to get set up with the Spencer Study Club. So email me at jason@transformdentalsleep.com. We'll get you set up, save some money, and change the trajectory of your practice. So Jamison, thank you. All of you, thanks for being here. Go forth, make it happen.
See you in January, everybody.